98% of infants, 93% of pregnant women, and 62% of children. And this includes children with special needs. Before assuming this current role, Dr. Warren served in various leadership roles at the Tennessee Department of Health, including the Title V Director and Deputy Commissioner for Population Health. He's a board-certified pediatrician, and before his state government service, he served on the clinical faculty in the Department of Pediatrics at the Vanderbilt University School of Medicine. So please give a warm welcome to Dr. Warren as he presents Accelerating Upstream Together to Improve Maternal and Infant Health.
Thank you for that. Good morning. I will say I was a July NICU intern, and with all the OBs and neonatal folks in the room, it's feeling a little bit like that again. So hopefully I'll be a little bit smoother than I was all those years ago. Really appreciate the opportunity to join you all this morning and to talk a little bit about and celebrate the fantastic work that you all are doing and think about how it contributes more broadly to the national goals that we have around improving both maternal and infant health. So we'll spend a little bit of time in the beginning talking about some key health indicators that you likely know well and put those in some broader national context. We'll talk about some of the key drivers of maternal and infant health outcomes, and in particular where there are opportunities to link those back to your improvement work. And then I want to make sure that I share with you all some key HRSA investments that we have in place across the country that are supporting the work that's happening in states and communities. And I hope there will be some ideas for additional partnerships that you may have from that. So just a little bit about the Bureau. As you heard, we are part of the Health and Human Services, or HHS family. So our sister agency, CDC, is across the street, but we're in the same family as NIH and FDA and CMS and those folks. Lots of folks don't know about HRSA when they think about HHS. So HRSA funds, for example, community health centers, federally qualified health centers. We fund the Ryan White HIV/AIDS program. We have a whole Bureau of Health workforce that funds things like National Health Service Corps and student loan repayment and nurse corps work. And then we have our Maternal and Child Health Bureau. Our mission in the Bureau is really about improving the health and well-being of all mothers, children, and families in this country. And we are focused in 4 key areas. Those are improving access, advancing equity, building capacity, and achieving impact. And so all of the programs that we fund, and we're primarily a grant-making agency, all the programs really focus on those 4 key goals. And in the Maternal and Child Health Bureau, we have this paradigm that we've been using for a few years now to frame the work that we do, and it's called Accelerate Upstream Together. And I want to spend some time this morning thinking about this framework with you all, and we'll walk through each part of it. The accelerate piece is exactly what it sounds like. We have to do more, and we have to do it more quickly. We've got to hasten the pace of change. And so I want to start out with an example around maternal health to make this point. So my predecessor in the Bureau published a report on maternal mortality. It's a lengthy report, but the summary of that is shown on the left, that clearly maternal mortality is preventable. No available figures show a decrease in the United States, and we tend to do worse than other countries. That doesn't come as a surprise to any of you all who live in this work every day. What might be a surprise to you is, I said it was my predecessor. It was not my immediate predecessor. It was 10 bureau chiefs ago. This was the first chief of the Children's Bureau in 1916. So 108 years ago, these were the summary points, and these are still the summary points. And my urgent plea is that the colleagues who sit in rooms like this 108 years from now are not having the same conversation. We have to think about how to accelerate the pace of change. We have made change, and so people say, but it's not as bad as it was 108 years ago. That is absolutely true. I think it also doesn't mean we can be complacent with where we were 108 years ago. So if you look back on the overall trends in maternal mortality, this blue line shows the overall trend in maternal mortality rates. And just to orient you, so on the x-axis we have years starting in the 19-teens. On the y-axis is maternal death per 100,000 live births. And you'll notice the scale's a little funny. It's a logarithmic scale, so you can actually see the vast difference over time. So in 1915, when we first started recording in this country births and deaths in a standardized way, the maternal mortality rate was over 600 per 100,000 live births. We are not anywhere close to that. So yes, we should celebrate that we have made marked improvement. But I would argue that anywhere on that y-axis should not be acceptable to us as we think about maternal deaths, and so we have a lot of opportunity to improve. So this is the overall line. This is the total maternal mortality rate in this country. What you'll see is there is that uptick at the end, and so you'll see that sort of hatched line that happened in sort of the 2000 to 2015 period. There was the introduction of what's called the pregnancy checkbox on death certificates, so a question that folks were filling out death certificates to answer about a pregnancy during the time period. That was added so that we could better ascertain the number of maternal deaths that were occurring. When we were relying previously on just looking at cause of death on the death certificate, if you've paid much attention to death certificates, you know the quality of those is not always the greatest, and so being able to determine was this a maternal death could be difficult. And so the pregnancy checkbox was added to be able to catch some of those. It is not without its flaws, and you've probably seen some recent publication around the challenges there. I think folks sometimes rush to dismiss maternal deaths and say, well, this is just a function of the pregnancy checkbox, but the reality is those deaths are still too high. And so you see where we've landed there. This is nationally. It's important to note that alongside this whole trajectory has been the existence and persistence of marked disparities by race. And so if we look at maternal mortality rates when we compare black and white women, historically there have been these disparities. You see the red line is the maternal mortality rate for black women, the darker blue line on the bottom, the maternal mortality rate for white women. And consistently over time there has been anywhere from a 2 to 4-fold difference or rate ratio in those maternal mortality rates. So not only are the rates high, but there are disparities that are unacceptable in these rates. So furthering that piece out a little bit around the disparities, when you get away from vital statistics and you start to look at things like maternal mortality reviews, you can actually get a bit more rich data. And on a number of factors, things like causes of death, but also even race, ethnicity. And so data that our colleagues at CDC have shared from their pregnancy mortality surveillance system show us that these disparities are there, again, particularly prominent among non-Hispanic black women, also non-Hispanic American Indian Alaska Native women, and non-Hispanic Native Hawaiian or other Pacific Islander women. One note about that bar, and you see the asterisk at the top, those numbers tend to get fairly small, and so from a statistical standpoint, those may fluctuate, but nonetheless, the disparities are there, particularly when you look at comparing with non-Hispanic white women. It's important as we think about what to do here, because it can be really easy to get lost in the numbers are bad and there's despair and what do we do, to start to unpack when are women dying and what are the causes of that. And so one of the early analyses looked at when during the course of pregnancy and the postpartum period do folks die. And I think as this work was taking off across the country, there was a lot of focus, and if you think about the AIM bundles, a lot of the early focus was really on that peripartum period. So a lot of work to think about how do we improve the quality of care around labor and delivery. And that's certainly important. If you look at this, this graph, on the x-axis you sort of have these windows of time from pregnancy out to a year postpartum. Those two bars in the middle there, day of delivery and that first week postpartum, they account for about 25% of deaths. And so it is absolutely important to think about how we focus there. But maternal mortality review committees have taken a broader look and actually followed out for the entire year following pregnancy. And so what you actually see is that more than half of deaths across the country are occurring in that period from 1 week to 1 year postpartum. And so as we think about moving this work forward, the work that you all are doing with your Perinatal Quality Collaborative, the work that's happening in similar collaboratives across the country, we've got to think beyond the walls of the hospital. We've got to think about how we engage clinical settings, outpatient clinical settings, but also other broader community determinants. And I was thrilled to hear the engagement that you all are having around the conversation around social determinants to think about how we might drive some of this work. So postpartum is an absolutely important period, and it's exciting for us to see that that's finally getting some of the recognition that it has deserved. So it's important to think about when these deaths occur. It's also important to think about why these deaths occur. And again, data from maternal mortality review committees has helped to give us some more robust data than we might see just on analysis of death certificates, for example. So this analysis was published by CDC a few years ago. This looks at 36 state maternal mortality review committees, and the leading cause of death in those states was mental health conditions. So whether that is suicide or overdose or other mental health conditions, that was a leading driver. One thing to note is that they break out a number of cardiac-related conditions that you see here. So there's the cardiac and coronary conditions line, there's cardiomyopathy, there's the hypertensive disorders of pregnancy. Collectively, if you add those up, that pushes that sort of broader cardiac category into the top. And so I think that really aligns with the work you all are doing here in terms of thinking about that AIM cardiac bundle and implementing that. It's also important to note that if you break out these causes by race, they differ. So when you look at a population of non-Hispanic white women, mental health conditions are the leading cause. But if you look at black women, those cardiac conditions rise to the top. And so it's important to think, what is our population? Who is the population we're trying to reach? What are the disparities we're trying to address? And what are the leading causes? And focusing your efforts there. One of the things that's always striking to me when I think about these data is one of the key pieces of information that we get from maternal mortality review committees that you can't get from vital records like death certificates is, was this death preventable? How many of you are involved with a maternal mortality review committee or even a child fatality review committee? So a number of folks. So the way these work for folks who aren't engaged, there's this interdisciplinary team that comes together to review various pieces of information about a death. These are not sort of name and shame and blame meetings. These are trying to understand, why did this woman die? What were the circumstances around that? Was this death preventable? And what recommendations should we take away from this very tragic event to prevent future similar tragic events? And so that key question around, was this death preventable, is part of every maternal mortality review committee. And in this analysis that CDC published, they noted that over 80% of the pregnancy-related deaths were preventable. As I travel around the country, what we see is this is not dissimilar from what states are finding. I was in Missouri a few weeks ago. Their number is actually closer to 90%. And so as we think about that 108-year story earlier, as we think about 80% of these deaths are preventable, I hope you are feeling urgency to get up out of your chair and deal with this today, and think about accelerating the work that you're already doing, and think about where there are gaps, where there may be opportunities to fill in. So those are all national data points. Wanted to really dive in and spend a little bit of time on your Georgia data. And I first want to congratulate you on having such a robust process in Georgia for reviewing these deaths, for being transparent and publishing these deaths. We have the opportunity to work with your folks at the Georgia Department of Public Health a lot. Diane Durrence and the team with Maternal and Child Health are just fantastic and doing amazing work. And I hope if you don't already know them, you'll take the opportunity to get to know them. I know they work very closely with the PQC, but they're in all sorts of things related to mothers, children, and families. And so they are good folks for you to know. One of the good things that they do in the work they support is this work of maternal mortality reviews and publishing state reports. These really have fantastic data to be able to help you think about how you focus your work and prioritize your efforts as you're moving forward. So in the latest report that's published online, about 113 pregnancy-related deaths over a 3-year period. So what's that, 35 or so deaths a year for a rate of 30.2 per 100,000. Not dissimilar from the rest of the country, the highest rates among non-Hispanic black women, also among women with high school or less education, and women who are on Medicaid at time of delivery. I always think this one is a really striking statistic, because sometimes people say, well, if we could just get people insured, we would solve all the challenges. And yet we know there are marked disparities by payer type, in this case Medicaid versus other payer types, and it begs the question of, what are those other drivers and what are those other things we could do to be able to address these deaths. If you look at your leading causes of death, so we were earlier talking about national level data, this is Georgia-specific data. So hemorrhage is the leading cause, at least during this 3-year period, followed by mental health conditions, and then cardiomyopathy and the cardiovascular conditions. When you look at that broken down by race, and your Georgia report does just that, hemorrhage and mental health conditions, the leading cause for white women, cardiomyopathy and those cardiovascular conditions, including embolic events, were the leading drivers for Black women. And so as you think about addressing disparities at the local level or the regional level, understanding those drivers is important. I mentioned earlier the preventability statistic. Again, the Georgia review found that almost 90% of the deaths here were deemed preventable through those multidisciplinary review teams. This slide looks at severe maternal morbidity. So a lot of the focus is on mortality, very tragic, and we also know that those severe maternal morbidity events can be just as tragic and have in some cases lifelong consequences for women. So the leading causes of those were related again to hemorrhage, and then you can see the distribution across other organ systems as we follow through. The overall rate for severe maternal morbidity, about 3 times, actually not 3 times, 109 per 10,000, so about 1,300 cases a year, so substantially greater than your maternal mortality rate. So as you think about how to keep women healthy across the life course, as you think about how to optimize care during pregnancy and the postpartum, avoiding these is important as well. And again, if you think about the work that you all are doing through your severe hypertension bundle, through your cardiac bundle, and the work you've done on the hemorrhage bundle to date, you really have made good progress in addressing some of these key drivers. So we've talked about the maternal piece. I want to spend a little bit of time talking about the infant mortality piece. A similar curve if we look at the overall shape. So if we go back to the 19 teens, we started out much higher, well over 100 deaths per 1,000 live births when we talk about infant mortality. And we have seen a steady trend downward over time. When we plot that by race and ethnicity, you can see higher rates for Black infants versus white, similar to what we saw in the case of maternal deaths. A persistent disparity rate anywhere from about 1.5 to 2.5 times higher rates among Black infants than white infants. And one of the things that I like to point out when we talk about infant mortality disparities is sometimes we talk in sort of epidemiology speak, and it's really easy to sort of fall into these habits of saying things like Black babies die at a rate 2 times that of white babies. And we say it so often, I think it sort of loses the importance and the meaning of what we're saying. So some of our colleagues have challenged us to think in different ways about how we quantify that. And one of those is thinking about this notion of survival lag. And so if you look at the infant mortality rate for Black babies in the latter part of this graph, 2021, that was the rate that white babies achieved in 1981, so a survival lag of 40 years. A different way of saying that is it took Black babies in this country 40 years to achieve the same infant mortality rate as white babies. So as we think about this notion of accelerate, we don't have 108 years. I would argue we don't have 40 years. We have to think about how to close those gaps. Ultimately, we want to get those numbers down for the entire population. We want to get the infant mortality rate, the maternal mortality rate down for everybody. And we know these disparities are severe, they are persistent, and so we have to work more quickly to eliminate those differences while we're also trying to improve outcomes for all. Specifically, if we dive into the Georgia data, so this horizontal line shows the Healthy People 2020 target, which was just around 6.0. Your Georgia rate over time has generally hovered above that. So the most recent year shown here was just above that at 6.3. We have seen a fairly steady, if not slow, national decline. So we achieved the Healthy People goal for infant mortality rate overall. We have never achieved the infant mortality rate goals for healthy people for Black and brown babies in this country. So we still have a lot of work to do in the space of eliminating those disparities. When you think about the drivers of infant mortality, well, we'll get to that on the next slide. If you think about the disparities, again, those are marked. You see the non-Hispanic Black rates are the highest, Hispanic and non-Hispanic white being there sort of in the middle, and then non-Hispanic Asian and Pacific Islander having the lowest rates in Georgia. Leading causes of infant death in Georgia, not dissimilar at all from the national pattern. So congenital anomalies or malformations or birth defects are the leading cause of infant deaths across the country from a population standpoint, followed by preterm birth and low birth weight, followed by what some people still call SIDS. We tend to not like to use that term SIDS anymore. We tend to talk about sudden unexpected infant deaths, but a lot of this data comes from death certificates, and folks still use that term SIDS, so that's why you see it represented here. than unintentional injury and maternal complications of pregnancy. This is the overall picture. If you think about the overall drivers of infant deaths, those vary, just like the maternal deaths, by race and ethnicity. And so what you see here, you sort of see these three clusters, non-Hispanic black infants on the left, then Hispanic, then non-Hispanic white. And in each of those, you see the bars representing the leading causes of death. The thing I want to point out is for the non-Hispanic black babies. So in the far left, that tall blue column represents deaths due to prematurity and low birth weight. And so as we're thinking about closing the disparities, while overall at the population level you may be thinking about reducing congenital anomalies, you want to think in terms of eliminating those disparities on how we focus on decreasing those deaths due to preterm birth and low birth weight among black infants. So that's the bad news part of the presentation. Hopefully it, again, has lit a fire for you to think about what you may want to continue doing, to renew your interest in doing, to think about how you can do more than you're currently doing or do what you're doing in different ways. And so the next part helps us to answer what that might look like, and that's the upstream part of this framework. In public health, we talk about this fable. Sometimes there's a person who's walking by a river, it's a beautiful day, and they're enjoying the serenity of this moment, and all of a sudden they hear splashing and screaming, and they look out and there's someone who is struggling in the river. And so they jump in the river, they swim out to the middle of the river, they grab this person, they bring them onto the shore. And as they're helping that person onto the shore, they hear more splashing and screaming, and they look and there's someone else who's struggling in the river. So they swim back out to the middle of the river, they grab that person, they bring them onto the shore. They're helping that person onto the shore, and lo and behold, they hear more splashing and screaming, and they look, and guess what? There's someone else who's struggling. And about this time, there's a jogger going by on the riverbank, and so they yell out to the jogger, "Will you help me?" And the jogger just keeps on going. And this person says, "Hey, why won't you stop and help me?" And the jogger says, "I'm going to go upstream and see why these people are falling in the river in the first place." And for those of you, if you think about the neonatology colleagues in the audience, the premature babies that you've taken care of, sometimes it feels like you spend your days taking babies out of the river, right? Premature baby, premature. What are the opportunities to go upstream and think about prevention? I like this fable for the most part. I do think it can create a perception that people are maybe doing something wrong or not paying attention and fall in the river. And so I like to sort of modify this and say, when we think about some of the structural drivers of poor health outcomes, when we think about things like disparities in the birth outcomes that we've talked about, in some cases it's not people falling into the river, in some cases people are being pushed into the river. So as we think about racism and the impact of bias and discrimination, we have to tackle those, and that's part of this upstream work as well. In the maternal and child health world, we talk about a life course approach. So there is this notion that all of us have this optimal health trajectory. That trajectory can be altered by either risk factors or health promotion factors, and ultimately where we land is the result of the balance between those two. This has been borne out in a number of studies over time. The weathering work that's been done, particularly to look at the longstanding effects of racism and discrimination on black women, has factored into this work and is really important as we think about, for example, improving birth outcomes. We have to think about the health and well-being of those individuals long before they ever contemplated pregnancy. And we have to think about how health across the life course sets us up for healthy birth outcomes. So I trained as a pediatrician, and I remember when I moved to the public health world and first started hearing about this maternal mortality issue, I thought, that's important, but that's really a problem for my obstetrical colleagues. I'll think about infant mortality, they'll think about maternal mortality. And I couldn't have been more wrong. And Life Course really teaches us that really there is this multi-generational influence on health and well-being. And so if we think about those drivers of prematurity, much of that is driven by preconception health factors. So mom's health before she ever became pregnant. And so as we think about the patient who is in front of us, we have to think about the health and well-being of their parents. And so how is this current patient's health influenced by the health and well-being of their parents? But also then downstream, how is the health and well-being of their offspring going to be influenced by their health? And so it turns out, in fact, as a pediatrician, and I was mostly in a primary care outpatient setting, the things I was doing to provide good, well care for young girls and adolescent females was actually potentially having a chance on the improvement of the birth outcomes for their offspring that they were going to experience. So we are all connected in this work together, both peds and OB. So if we think about that, and we think about the challenge we face with birth outcomes in this country, and we think about the health of young girls and women in this country, we can understand why we see some of the outcomes that we see. So if we think about the health of young girls, if we think about young girls who are overweight or obese, more than a quarter of them, if we think about the experience of traumatic events during childhood, what we call adverse childhood experiences, more than 40% of folks report at least one adverse childhood experience. We know from good studies that were first conducted in California that have been replicated across the country that there is a dose-response effect to the experience of ACEs, or those adverse childhood experiences, and later complications in adulthood, whether that's the experience of particular health behavior risk factors, whether that's the experience of chronic disease, whether that's the experience of early death. And so all of those experiences are related to those adverse outcomes later in life. If we think about women of the 18 to 44 age range, many of them are not seeking preventive care, so about a third without a well woman visit in the last 12 months. 1 in 10 would describe their health as fair or poor. A substantial number of them smoke. About 60% are overweight or obese, and then many women live not only below the poverty level, but substantially below the poverty level. And so all of these factors together combine to contribute to these outcomes that we are seeing across the country. Now, I mentioned I was a July NICU intern, and I remember by the end of that first month getting to the point that I felt a little bit more confident on those daily rounds, and there was a lot of prematurity in our nursery. This is Dr. Bill Walsh, who is a neonatologist at Vanderbilt and who was my attending for much of that first month. And so after a few weeks, I started to feel more confident, and I could talk about TPN, and I wasn't scared to touch the ventilator, and I understood what blood gases meant, and sort of how to pick up that baby and examine them. And so I was feeling pretty good about myself, and I could rattle off all these things during rounds. And then Dr. Walsh goes and asks me, but why was this baby premature? And I was so focused on the isolette and caring about this baby in front of me that I hadn't thought about those broader implications. He's one of these folks that I sort of hold up on a pedestal for me as a role model because he did this amazing clinical work at the bedside. He was an amazing researcher, and he was engaged in this broader public health work. And so he participated in fetal and infant mortality reviews. And he was asking that question to get all of us around the bedside interested in this question of, but what can we do to prevent cases like this from occurring before? And I think for so many years that has been left out of medical and nursing and postgraduate training curriculums, and there's a real opportunity for us to think about how we infuse this upstream thinking into the work that we do. There are some models in the public health space that help us to answer these questions like this. So there is this tool called perinatal periods of risk. This is done at the population level, so large counties do this, states often do this, and they look at fetal and infant deaths, and they categorize them along these two axes. So they look at the age of death, was this a fetal, neonatal, or infant death, and then they look at the weight at the time of death. And they fall into these broad buckets. So for the lowest weight, so less than 1,500 grams, generally, regardless of when the deaths occur, those are typically tied back to some factor related to maternal health or prematurity. For deaths that occur in the fetal period but greater than 1,500 grams, in many cases, those are linked back to maternal care. For those deaths in the neonatal period, something around newborn care. And then from a month out to a year postpartum, broader factors related to infant health. Now, these are general categorizations, but when you're thinking at the population health level, this can help give you an idea of where you may want to focus your efforts. And so you can extrapolate, for example, if you've got lots of these deaths, if you're the state of Georgia and you want to look at where are ways we might intervene, and you've got lots of death in the infant health category, you could think about things like safe sleep. You could think about promotion of breastfeeding. You could think about unintentional injury prevention. If you've got lots of your deaths that are due to preterm birth and low birth weight, you would think about that maternal health block, so preconception health. How are you creating environments that support optimal health behaviors? How are you thinking about improving access to prenatal care and making that readily available early on? This can guide your work. It's going to be community or state specific, but it's a great tool to help you think about some of those upstream factors and how to incorporate those into your work. This notion of upstream is not just some sort of feel-good thing that public health folks have cooked up. A number of researchers have looked into this, and this has been borne out across the literature. And what we found over time is that when you look at the drivers of overall health and well-being, it's largely not clinical care. It's not that clinical care isn't important. Clinical care accounts for about 10 to 20% of our overall health and well-being. But if you look at those other factors, health behaviors, community and environmental factors, genetic susceptibility, collectively those account for far more of the drivers of health and well-being than clinical care. And so we can't dismiss the importance of clinical care. It is absolutely necessary, but it is not sufficient in the bigger picture to help us achieve optimal health. And so as we think about this journey that we're all on together, clinical and public health folks and community partners, we've got to think about those other drivers and how we think upstream. So we talk a lot about the social determinants of health. Those are the factors in the environments where we live and learn and work and play. As a pediatrician, I think about, for example, children that I would see in clinic who were over the top of the growth charts in terms of being overweight or obese. And my clinical counseling to them was things like, eat healthier foods and be more active. But if they lived in the part of Nashville where there were substantial food deserts, if they lived in neighborhoods where it wasn't safe for them to be physically active, if their school wasn't funded to have freezers and refrigerators sufficient to store fresh fruits and vegetables, or to have the preparation space to be able to do that rather than sort of pre-processed, pre-made foods that can just be heated, you start to see some of these root causes of disparities. And so I could say all day long in clinic, eat healthier, be more active, and yet I would see these kids in follow-up 3 months, 6 months later, and often they weren't getting better. Many times they were getting worse. For me, that's part of what drove me into this public health work. It was the systems kinds of things, the things in the community that I couldn't have any control over in the clinical setting that were really frustrating to me and presented opportunities. Social determinants of health is the word we often use to talk about those kinds of things. So it is access to having health care, quality health care, but also things like the neighborhood and built environment. So again, things like zoning laws, things that none of us are trained to be able to do, but understanding the placement of grocery stores versus the placement of liquor stores, for example, the placement of sidewalks in communities where folks can be physically active, green spaces in communities where people can be out and be physically active in a safe way. The social and community context, a lot of growing interest right now in this notion of isolation and the impact of isolation on health, and what is to be said for social cohesiveness and community engagement. And then, of course, economic stability and education. All those together influence the health outcomes that we're seeing. I don't expect any of you to go back in your neonatal units or in your OB clinics and start to think, okay, I've got to tackle education and I've got to tackle housing and all these things. We don't have those tools. But you've got partners in the community who do. And you've got partners in public health who do. And the folks who are in the Perinatal Quality Collaborative are thinking in that space. And again, kudos to the planners for thinking about even introducing social determinants of health to a conference like this, because I think it helps us all think about the role we play and bringing that clinical piece into the work that is so important, but also connecting with partners who can also help us move this work forward. Now, when we think upstream, it doesn't just stop with social determinants of health, because the reality is you and I could live in the exact same neighborhood, we could live the exact same distance from a birthing hospital, and yet have very different experiences there. And so structural determinants, things like racism and discrimination and bias, governing processes and the way those have been set up over time influence the way that individuals experience those social determinants of health. And so it is important to think upstream and think about social determinants, but I want to challenge us all to think about those underlying structural determinants and what is our role in helping to address those as well. You'll remember that in our AIM bundles a few years ago, we added a fifth R, the R of respectful care. As folks started thinking about disparities, there was initially this question of, should we just introduce a new bundle to sort of address equity or solve for equity. And the reality is there's not a bundle that will fix equity, because if there was, we would have been doing that a long time ago. But it's also not the case that we should just sort of have the equity work here and then all the rest of the work here. It has to be infused in everything that we do. And so the decision was made to weave in this notion of respectful care across all of those bundles. So whether you're thinking about sepsis, whether you're thinking about hemorrhage, whether you're thinking about preventing primary C-section, respectful care plays into all of those. So the last part of this framework is together, and I just want to emphasize none of us does this work alone. Families are always, or should always be, at the center of the work that we're doing. Families, consumers, however you want to think about that. It's the individuals that we are working for every day, and we want to keep them at the center. All of us coming together means clinicians, it means public health folks, it means academic folks, it means governmental folks, it means folks who work in community-based organizations who all collectively together have the tools to solve these problems that none of us individually has on our own. So just a little bit about the work that we fund in states to give you a sense of some of the things that you have here as resources. Our work broadly focuses on 3 areas: promoting access. So we have things like home visiting that's available in many counties across your state here in Georgia. Georgia has actually put additional state money behind that. Both your governor and legislature have infused additional money, which is fantastic. We've got our block grant, which supports basic core public health infrastructure, things like newborn screening, things like injury prevention, things like family planning. We also support preventive services through Women's Preventive Services and Bright Futures. When the Affordable Care Act passed in 2010, there was a provision that preventive services had to be covered without any cost sharing, and we were the agency tasked with developing what those preventive services are. So we have a set for women, we have a set for children, and then there's also the newborn screening panel. So all of those are designed to reduce barriers to access. We've also got a portfolio of work that focuses on improving quality of care. So AIM is the one that's very familiar to you all. Those safety bundles that started out with just a few, we're now up to many more than that, and that list continues to evolve as we think about the drivers of maternal mortality and morbidity. We're excited that in the last year, we've awarded almost 30 grants to states to be able to further expand their AIM capacity. Right now, we're at the point where AIM is being implemented in all 50 states, about 2,000 birthing facilities across the country, but that's not all the birthing facilities, and so we want to get to all of them, and this AIM capacity program is a way to help us do that. We are also, in terms of thinking about quality, we've got state maternal health innovation grants, integrated maternal health service grants, where we're giving states money to deploy innovative solutions based on the unique drivers of maternal mortality and morbidity in their state. And then, as I mentioned, we've got substantial workforce investments. Just within our Maternal and Child Health Bureau, we've got a growing body of work supporting community-based doulas, particularly through our Healthy Start program. We just in the last year have launched a new research collaborative for minority-serving institutions. Morehouse is one of those, and advancing that work here. And then we also are focused on supporting the practicing workforce. So we have a maternal mental health teleconsultation program that's now in 12 states that integrates behavioral health work into primary care. Georgia actually has a state perinatal psychiatry access line. It's not one of the ones that's funded by us. Like I said, we're only in 12 states at this point, but that's your analogy to the work that we are supporting in the other states. We are in the middle of an enhancing maternal health initiative. We are engaging 12 states across the country. Georgia is one of those states. We'll be back here on Monday at a federally qualified health center in Atlanta, talking with stakeholders about how we can work across our various funding streams and the grants that we fund in states to think about advancing maternal health. We started out with a kickoff in DC. We were just in Missouri a couple weeks ago, and then we'll reach the rest of the states by the end of this year. The goal is to get people thinking about how they work together across these grants that are already funded in states. So just to give you a flavor of what's here in Georgia already, at the top, Title V, which is your Maternal and Child Health Block Grant. Again, Diane and her team do an amazing job. They're about to start the 5-year needs assessment. Every 5 years, they do this comprehensive needs assessment that says what should drive our action plan for the next 5 years. And so if you're not already connected with them about that needs assessment, I would encourage you to do that. They want to hear from partners about what are the needs across the state and what can the block grant be used for to help address those needs. You've got Healthy Start sites, which are community-based organizations focused on improving maternal and infant health with a main goal of reducing infant mortality and also associated disparities. You've, of course, got AIM. You've got your State Maternal Health Innovation Program, the Minority Serving Research Program I mentioned at Morehouse. McPhee is the evidence-based home visiting program, programs like Nurse Family Partnership and Parents as Teachers and Healthy Families America deployed in communities. And then we've also got our National Maternal Mental Health Hotline, which, as the name suggests, is national, but folks in Georgia have access to that as well. So all of these are resources funded by us that you have access to today. And if you don't know about them, I'd encourage you to think about how you can learn more about those programs and connect with those community partners and make those linkages for the patients and families that you're serving. So I want to close really quickly with some concrete opportunities to think with you about improving maternal and infant health. I mentioned on an earlier slide the National Maternal Mental Health Hotline. I want to make sure that none of you leaves without knowing this number. I hope you'll program it into your phones. I hope you will take note of this QR code and think about some of the promotional opportunities to be able to share this with the families that you served. We launched this in 2022, so almost 2 years ago on Mother's Day. This is a line that's available 24/7. It's free, it's confidential, folks can call or they can text, and they get connected with a professional on the other end, maybe a physician, maybe a nurse, maybe a counselor or a social worker who can help them with whatever they're calling for. Calls are responded to in both English and Spanish, as well as 60 other languages that we have access to through translation services. The number for that is 833-TLC-MAMA, M-A-M-A. Folks can text or call that number. This QR code will take you to promotional materials, so traditional things like posters and flyers, but also wallet cards and magnets. We make those available for free. So I hope that a year from now, you will have these posters up in all of your labor and delivery spaces, your NICU rooms, anywhere where patients might gather. You'll partner with community folks to get these out, in laundromats and other places where folks are, because it's really important to get this word out, particularly as mental health conditions are a leading cause of maternal deaths, as we know, nationwide. In the first couple of years, when we look at the experience of this hotline, the leading causes for folks calling are feeling anxious, overwhelmed, or depressed. And if you've ever worked with a pregnant person or a new parent, you know that those are not uncommon at all. And so we're really glad that this line exists as a resource to be able to address those concerns. It is not a crisis line, so as you all know, there's the 988 crisis line, the suicide prevention line. If folks call in crisis, we have an agreement to do a warm handoff, so we stay on the line with them and make sure they get connected with someone on the crisis line. We have gotten about 30,000 calls to date on this, but we have a lot more capacity to take more, so I would encourage you to think about how you can spread the word on the hotline. You already know about AIM. We're excited to continue to think about how we scale the work of AIM. So the bundles that have been implemented, how do we move those to a sustainment phase to make sure that the good work that has happened across the country is not a one and done, but that gets continued because it just becomes part of what we do in settings across the country. You see the safety bundles that have been developed to date. You will recognize a number of them that you have already implemented in Georgia on the maternal side. Know that you also have a neonatal side, which is exciting as you're thinking about the importance of caring for the dyad. One of the things that we do as we go across the country is we help folks who aren't clinical or don't understand AIM understand the importance and the difference that AIM is making. So this is the stock slide I use, and you will see Georgia features prominently on that slide, really reflecting the work that you all did in hemorrhage. And folks often say, well, I don't understand AIM. I don't understand what it is that folks do. And so the hemorrhage card example is an easy one for folks to get their head around as we think about what are those sort of ingredients that are in the recipe for you improving care for hemorrhage, preventing or responding to hemorrhage. And so being able to walk them through understanding that you can assemble supplies in advance. You can do drills on those supplies. You can help folks understand which drawer they need to go to find this. You can have order sets. You can have ready in-place agreements with the folks who are in your lab to understand, and your blood bank to understand and to think about what they need to do in those settings, and you can practice it. So the work that you all have done here and around that bundle in particular has been tremendous. Over time, seeing a 96% increase in the availability of hemorrhage carts. You can see that not all states are focused on hemorrhage. They're focused on what it is that is driving the causes of maternal morbidity and mortality in their states. So Alaska is focused on hypertension. Illinois and New York have been focused on substance use disorder. We know that many states, just like you all, have deployed multiple bundles. And so we could go through all the states that have done this and talk about their success stories, but wanted to pull this out and congratulate you on this fantastic work and know that every state I go to, we give a shout out to Georgia. One of the areas that is of growing concern and interest to us is the changing landscape with regards to availability of obstetric services. It is hard to pick up the newspaper or sort of read the news online any day without seeing about another hospital closure, particularly in rural areas, but not all rural areas. And if it's not a full-on hospital closure, it's discontinuation of labor and delivery services. We know that the reasons for that are complex and many, and yet births still happen. And so we have to think about how to be able to respond. And it's not just births, right? We think about the entire spectrum of care, and we think about broadly about obstetric emergencies. So our partners at AIM have developed a resource kit for thinking about obstetric emergencies. We at HRSA were really excited that in the President's budget that was just released a few weeks ago, the President's budget for fiscal year 25, there's an additional $15 million to be able to support obstetric readiness in settings of maternity care deserts. So these are settings where there has been a loss of maternal services and a lack of OB providers. One thing that I always try to emphasize, sometimes folks in DC say things that don't necessarily make sense, like, do we want to have births in emergency departments? And the answer is no, we don't want to have births in emergency departments, but we want them to be ready should they happen, right? So I spent about a decade in Tennessee before coming here, or before coming to DC. And one of the things you know is that in rural areas, sometimes the closest hospital is the one where you see the blue H sign on the highway, and you don't know if they're a level 1 or a level 4 facility. But if precipitous labor is happening, it's where you go. And so we want to be able to make sure that folks are able to respond. But the goal of this is not, I always want to be very clear, not to incentivize births in emergency departments, but to make sure they're ready. We've got a long-standing history in this space of emergency medical services for children, making sure that emergency departments are ready to take care of kids. We want to now think about doing the same thing for obstetric emergencies. Want to last close with a quick blurb on congenital syphilis, just what everybody wants to hear about after you eat breakfast. But as you all know well, we have seen a substantial rise in the cases of both primary and congenital syphilis across the country, about a 10-fold increase in the last 12 or 13 years for congenital syphilis. As we think about this notion of preventability, just like maternal mortality, morbidity, about 90% of these cases are preventable if we could test in a timely way and get treatment to happen. In many of the cases that have been reviewed, moms didn't get prenatal care during pregnancy. And so we know that addressing barriers to access are going to be really important there. Some ways you can help. Again, this QR code will take you to resources. Think about how you can partner and collaborate with organizations that are providing care to women during pregnancy. How do we get women in early? How do we think about testing and treatment? Sharing the information that you all know well about the importance of screenings. This slide is actually even a skosh outdated since we turned it in a few weeks ago. ACOG has just come out with updated guidance around screening recommendations. So it's that first prenatal visit, it's third trimester, and then it's that birthing encounter, making sure that we don't miss any of the opportunities to be able to identify and treat these cases. This has been complicated by the national shortage of bicillin. We are hearing from partners that that is getting better. We know that extensiline has been available, but is not a cure-all in terms of availability. And so there are lots of factors that are making this particularly challenging, but know that this is important, and I appreciate that you all are engaged in this work. Our colleagues at CDC have actually created county-level resources to help you understand your county-level rates. That can help you, again, if you're thinking at the regional or statewide level about where you want to focus. So, a lot we've covered in the last little bit. You can see we've got significant opportunities to improve both infant and maternal health, not only in Georgia, but broadly in the United States, and that includes paying attention to those marked and unacceptable disparities. I hope you have heard that clinical care is important. But it's not the only thing we need to think about. It's necessary, but it's not sufficient, and we've got to think about those broader drivers of health. And then finally, none of us can do this alone. And I think the notion of perinatal quality collaboratives really embody that so well. No single provider can do this alone. In fact, one of the things we often learn in this quality improvement work is it's the system. It's the way our systems are arranged and set up, and policies and the way we approach the work that result in many of these outcomes. And so PQCs really have done a fantastic job across the country, including here in Georgia, at getting at some of those root causes and thinking about how we work together to address those. So thank you for your time, and if we've got time for questions, happy to entertain those.
Great. Thank you, Dr. Warren, for kicking us off today and for giving us that broad overview. If anybody has, we have about 5 minutes for questions, so just raise your hands, and I'm happy to walk the microphone to anybody who would like to ask a question.
And while you're thinking, I got excited and skipped my last slide, which is I always like to cover. So, I started off talking about national rates, and if we think about sort of gears in a machine, ultimately what we're trying to move are these national rates. We're trying to drive these national improvements. But that doesn't happen if you all don't come to work every day and do the work that you're doing at the hospital level. And I think sometimes that gets lost, and so I always want to recognize the tremendous work that's happening at the local level, because that's really what starts these gears turning. Yes, I'm a former chief resident, so I love PowerPoint animation. But this hospital level change happens. That drives change at the state level. So as you've got this collective of hospitals participating in Georgia's PQC, you are making change across the state, and ultimately that's what drives this national level change that we are trying to move. But the point is, none of this happens without the work that you and your teams back home do every day. So thank you for that work. Thanks for indulging the animation.
So while people are mulling questions, I'll ask with, one of the nice things about perinatal quality collaboratives is you can reach from broad organizational levels all the way down to clinicians and providers at hospitals, and those have grown now to encompass most states. I wonder if you could talk a little bit from your perspective about how HRSA and other groups can ensure continued support of infrastructure for these important collaboratives.
Yeah. It's a fantastic question. I think the clinicians have been on board for a long time. I think it's sort of in our blood, right? We came into this work to help people. We want to improve outcomes. And so I think it was not hard at all to get clinicians bought in. I think some of the systems level buy-in has been more difficult for folks. I'll give you one example, and then I'll talk about how we can support that. When I was in Tennessee, we had the Perinatal Quality Collaborative, and when they first started, one of the projects that they wanted to focus on was admission temperature for the baby, and thinking about how we optimize that admission temperature. And they started to think about, how do you control the temperature in the labor and delivery suite? And so they recognized some of that was provider preference. Some of that was controlled institutionally. And so they started to recognize they needed a change. And then they realized nobody had the key to the HVAC box to be able to do it. And that required someone in facilities, which required permission from someone in administration. And those folks weren't used to thinking about things like the admission temperature of that newborn baby. And so it was a way to bring them along to get to some of these systems factors. I think the sort of feel-good nature of this drives some systems folks, but what really is driving it when there's payment and policy change behind it. And so our colleagues at CMS have recently introduced the birthing-friendly designation. Some folks may know about this. So in the structural quality measures that the Center for Medicaid and Medicare Services now have, hospitals have to attest, are they participating in a perinatal quality collaborative? Are they implementing safety bundles? So this is one way that we at the federal level can drive this work, and I think support the ground level work that clinicians want to do by getting their system administrators and sort of C-suite folks interested in this as well when there start to be some implications to payment. Of course, anytime we can put additional money behind it is good, so the support we've been able to provide to states, again, we're, I think, at 28 states that have the AIM capacity grants. That's limited only by the funding we have, so if we get more funding, we'll be able to support more states. But I think a combination of those kinds of grants activities, but also policy changes get to those changes you're trying to do.